For our next chapter, we want to talk about disturbances in gas exchange. This is very important in evaluating sick patients. And they will ask a couple of questions on the boards when they talk about pulmonary patients concerning this issue. So there's two formulas that we need to know a little bit about. Not 100%, but we need to know a little bit about. The first formula is the formula that tells us about oxygen delivery. Oxygen delivery, what I mean by oxygen delivery is oxygen delivery to the vital organs. What are the parameters that go into oxygen delivery at the vital organs? That's what I'm really asking here. And if you look at this formula here, right here, the first one about oxygen delivery, you'll see you don't have to memorize this. You need to know the concepts though, because I'm going to give you the question that they've asked on the boards. Here it is. Oxygen delivery equals cardiac output, this is CO, cardiac output, times hemoglobin, times this coefficient for hemoglobin, times the hemoglobin saturation, and then you add on to that the partial pressure of oxygen. This is the diluted oxygen in the blood. This is the one that we get in the ABG when we check it. And this is multiplied by this coefficient, 0.0031. Now, we don't have to know this whole formula, but what do you get out of this formula? That, yes, when a patient comes in and is dyspneic and hypoxemic and so forth, the first thing we do is we slap on some oxygen on the patient and we make his PaO2 go up. It goes up from 50%, right, from 50 millimeters to, 100 millimeters. Okay, that's fine. But look at this. This part here plays a very small role in the total delivery of oxygen to the vital organs. It's a part, but it's a small part right here. So it's not, it's not totally negligent because, you give the patient oxygen really quickly and correct that, but it's not the first thing that really is going to matter in this patient. But two other things matter, and that's what they test. One is the cardiac output, right? You have to be able to maintain stable cardiac output to maintain the oxygen to the vital organs. So they tell you, what is the one most important things in patients presenting with dyspnea and stuff like that? Well, they have to have normal blood pressure. They have to have normal fluids. They have to have normal perfusion of organs. Anybody who's hypotensive, no matter how much their oxygen is, they can't perfuse the vital organs unless their cardiac output, right, and their blood pressure is stable. The second thing, and it's probably the most important thing in terms of the boards, is this thing about hemoglobin right here, where we need enough hemoglobin in our body to be able to bind to oxygen and then deliver it to the vital organs. So it's not dilute oxygen in the blood that gets delivered much to the vital organs, but it's the hemoglobin that grabs onto oxygen and is able to deliver it to the vital organs. So they ask you, what is the most important thing in a patient who is hypoxemic, who has a lot of medical conditions and is intubated and stuff like that? What is the most important thing that we maintain? The most important thing in this patient is to maintain the hemoglobin level above 10. Hemoglobin level above 10, hematocrit level above 30. So when we round in the intensive care unit patients and we present patients that are really sick and have multiple medical conditions, that they're hypoxemic and all that stuff, and they're on ventilators, and the attending asks, well, what's the ABG? Well, he knows that you're going to be able to, take care of that with the ventilator, but then he says, what is the hemoglobin and hematocrit? And he or she is getting at this thing right here, that you have to have a normal hemoglobin and hematocrit to be able to deliver oxygen to the vital organs. That's very, very important. So if they present to you a patient who's hypotensive, who's hypoxemic and all that stuff, and their hemoglobin is less than 10, you have to transfuse that patient, the hemoglobin above 10, in order to be able to deliver oxygen to the tissues. If you don't, you could give them all the oxygen you want from the ventilator, you're not going to be able to get it to the vital organs. So this is the premise And the theory behind this formula here, that you understand that in order to be able to give oxygen, you got to have oxygen, yes, on board, but you have to be able to deliver it to the vital organs, and that's through hemoglobin. So those patients, if they tell us about a patient that's hypoxemic, check the hemoglobin, they're asking you to transfuse the patient back to normal hemoglobin levels to be able to deliver oxygen to the vital organs. And that's all we need to know about that. We need to know that concept. We don't need to know the specifics of this formula. We never use it. We never use it clinically. We just need to know the concept behind it in order to be able to make clinical decisions. The second formula is the alveolar arterial gradient. And now that's a little bit more important formula in terms of clinical use, because we do this every day. You know, we get an ABG, and what we do on that ABG, we calculate the alveolar arterial gradient in order to be able to say, listen, you know, this patient is hypoxemia, but what is really going on? Where's this hypoxemia coming from? That's what the alveolar arterial gradient tells us. Where is this hypoxemia coming from? A patient that has pulmonary disease as a cause of the hypoxemia, their alveolar arterial gradient is elevated. I'm going to explain that to you in just a couple seconds. So what is this alveolar arterial gradient? Well, most of us, all of us, I should say, have an alveolar arterial gradient. And what this gradient really means is that there is a difference, a difference between the amount of oxygen, the partial pressure of oxygen that we find in the blood versus the partial pressure of oxygen that is in the alveoli. There's a difference. That difference is called the alveolar arterial gradient. Now, if you measure the partial pressure of oxygen in the alveoli, that's big A, P big A, oxygen in the alveoli. We don't usually do that. You'll get a number around 100. So most people that have no medical conditions, if you go into the alveoli and you do some really sophisticated measurements, you'll measure that alveolar oxygen, the partial pressure of oxygen in the alveoli, it's going to be around 100. And a way to do that, you know, through a formula is through this equation right here. Right here. This part right here, see where the arrow is? The 150 minus 1.25 times the PaCO2 gives us the partial pressure of alveolar oxygen, right here, just this formula right here, within the parentheses. So the 150 is this coefficient from the alveolar gas equation, and it says that if you subtract from that the partial pressure of CO2 times a coefficient 1.25 or divided by 0.8, you could use that formula too, same thing, it'll give you what the partial pressure of oxygen is in the alveoli. Under normal conditions, it's 100 because, look at this PaCO2 is about 40, right? And you multiply that by 1.25, 0.8, figure about 50, and you subtract that from 50, you get 100. And that's what your PaO2 is, Pa in the alveoli, Pa. And now you get the partial pressure of oxygen in the alveoli, and you subtract from that the partial pressure of oxygen that we get from the ABG. See, we use the partial pressure of oxygen from the ABG, and we use the partial pressure of CO2 from the ABG, because otherwise we would have to do all the complicated stuff I just told you before to be able to go in the alveoli and measure this. So we use the partial pressure of CO2 to get the partial pressure of oxygen in the alveoli, this stuff right here. So look at this. What do? Let's take a case then, and you got a 65-year-old man who's admitted with dyspnea and shortness of breath. His ABG is 7.45. That's a little bit of alkalemia, right, because it's above 7.4. His CO2 is low. A normal CO2 is 40, so his CO2 is 20, and his partial pressure of oxygen, now this is in the arterial, right? This is in the blood, is 60, and his saturation is 92%. So he's a little bit of alkalemic, his CO2 is low, his oxygen is low because he's breathing fast, right? He's blowing off CO2. You get all this stuff from the ABG. So I say to myself, okay, I want to know the AA gradient. I want to know if this guy has something in the lung that would cause this. And how do I know? Because my AA gradient would be elevated in that case. So I do my arithmetic. I plug in that formula, 150 minus 1.25 times CO2 minus my partial pressure of oxygen. And now I get 1.25 times the 20, the CO2 is 25. I subtract that from 150, and I get 150 minus 85, and my total AA gradient now is 65. So I have a patient with hypoxemia, admitted with shortness of breath, hypoxemia, that has an alveolar arterial gradient of 65. Now, remember I said all of us have a normal gradient. It's usually less than 10, about 5, because not all arterial blood gets oxygenated. It bypasses sometimes oxygenation and it goes into the left side of the heart by these Thebesian vessels. So we all have an AA gradient. That's normal. And it's usually about 5, usually never above 10. Anything above 10 for your purposes is usually abnormal. This guy's alveolar gradient is 65. So that's very high. So what does that tell me? Why did I just do this? Well, it tells me that this guy's got a problem, that's something in the lung. Something in the lung. It's obstructing oxygenation. It may be that this guy's got a pneumonia. Maybe this guy's got pulmonary embolus. I can't see it on the x-ray, but he's got pulmonary embolus, and that's why his gradient is elevated. Or, rarely, it's a right to left shunt in the heart. That would be another cause of an AA gradient. So for your purpose, anybody that comes in with hypoxemia, when you look at the AA gradient, you do it to decide, is it in the lung or the heart, to confirm that. If the AA gradient is elevated, it tells me that a patient with hypoxemia has some kind of process, usually in the lung, whether it's an infiltrative process, whether it's a pneumonia, whether it's fluid in the lungs like pulmonary edema or pulmonary thromboembolism, it's likely something in the lung. Then, if I don't have that as a diagnosis, then my second possibility would be a right to left heart shunt. Usually those cases we know about because they've been diagnosed before, in the adults anyway. That's what we do with the ABG right away. We confirm that right away, and then some people ask me, well, wait a second, you know, what if you find a patient with hypoxemia and they don't have an AA gradient? And that's a great question, because that's another question that we may be asked on the boards, that they tell us, they give us a hypoxemic patient that doesn't have an AA gradient, and then where's the hypoxemia coming from? And the answer is the hypoxemia is coming centrally, like for example, a patient on opiate overdose. Their respiratory rate now is down to 6. Normal respiratory rate is 12, 14, and these patients are breathing at 5, 6 per minute. They get hypoxemic. They get hypoxemic, but they also get hypercapnic at the same time. So because their CO2 rises, the AA gradient is not increased. The second possibility of a patient with hypoxemia and a normal AA gradient would be somebody who's up at high altitude. That would be another possibility, or at a room where, you know, the oxygen supply is decreased. I say that second and third because usually those are not the typical classic scenarios we get in the clinical setting. The typical case scenario that we get in the clinical setting is somebody who's hypoxemic comes into the emergency room with confusion, altered mental status, and we do the ABG, hypoxemic patient, but with normal AA gradient, look for opiate overdose in that patient. Otherwise, everybody else with an elevated AA gradient and hypoxemia, think about lung processes, think about right to left shunts, and so forth. And this concludes the disturbances in gas exchange.